The Jerry Pal podcast is brought to you by Archstone Foundation. Archstone Foundation, improving the health and well-being of older Californians and their caregivers.
And supported by listeners like you, many of whom have donated on the Jerry Pal fundraising site, which you can find at www.jerrypal.org, big blue button, or through reviews, stars on your favorite podcasting app. Big thank you. Welcome to the Jerry Pal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do we have with us today?
Today, we are delighted to welcome Gwen Bernacki, who is assistant professor at the University of Washington and the VA Puget Sound and is a non-invasive cardiologist. Welcome to the Jerry Pal podcast, Gwen.
Thank you.
Wait, we've had a Bernacki on before?
Yes, Rochelle.
How are you related to Rochelle?
I am her little sister. She has always called me her little sister, and so I don't think I'll ever be the younger sister or other sister.
We're also delighted to welcome Ashok Krishnaswami, who is a clinician researcher at Kaiser Permanente and a geriatric cardiologist. Welcome to the Jerry Pal podcast, Ashok.
Thank you both. It's wonderful to be here.
Okay, Gwen, I think you have a song request for Alex. So before we get into the topic of TAVRs and periprocedural code status, you got a great paper in JAGS that we're going to review. You got a song request for Alex?
We do. The song that we've chosen is Cold Heart by Elton John and Dua Lipa. We didn't actually choose the song because Elton John is 75, and some might say he's geriatric, touring the world with these new lyrics. We actually chose the song because it's the lyrics are a blend of 4 classic traditional Elton John songs, and the lyrics together bring new meaning. And you can hear that. You can hear that new things can happen when people collaborate.
Well, something new is going to happen when I sing this song. We'll see what happens. Okay, here we go. Cold, cold heart, hardened by you. Something's looking better, baby, just passing through. And I think it's gonna be a long, long time till touchdown brings me round again to find I'm not the man they think I am at home. Oh, no, no, no. And this is what I should have said. I thought it, but I kept it. Cold, cold heart, hardened by you. Some things looking better, baby, just passing through.
I love songs that push Alex.
That pushed me a little too far. Everybody go back and listen to the Elton John and Dua Lipa version. That's much better.
Just insert that right on top of it. So you mentioned the importance of collaboration, and that's part of why you picked the song. What does this have to do with TAVRs?
Well, for starters, I loved your interpretation of the song, Alex. Absolutely loved it. I think the first 2 lyrics of the song, and I'm not sure if you started there, was "It's a human sign when things go wrong," and I think that a discussion of TAVR is very well suited to those lyrics. Certainly, from the perspective of the valvular disease, and then, of course, from the perspective of what can go wrong in the cath lab and thereafter.
And you've got famous people having TAVRs done.
That's right. That's right. Mick Jagger had a TAVR done not too long ago, a few years ago, when he was 75. And aortic stenosis is really common. 1 in 10 over the age of 80. So the idea of cold heart, this is, we really can't have cold hearts when it comes to this.
Oh yeah, Ashok, I got a question for you.
Yeah.
this one has been bugging me since I've heard about TAVRs. Is it TAVR or TAVI? Because I have seen it a lot of different ways. Do we use TAVI more now?
So first I have to say, I think they're both used. I think it depends on who is doing it. I've also, had that, in my mind, who actually taught about TAVI versus TAVR. And so you're point on in that, but I've been using TAVR. I think in the regular discussions, it's usually TAVR, rarely TAVI.
Yeah, it sounds better. And what is a TAVR?
Sure. I mean, it's basically what the actual, if you expand it, it's called transcatheter aortic valve replacement. And it really just means that where we used to sit and do stuff by surgery, you'd have to kind of go through surgery, open you up, and then do all this implant stuff surgically. Here, you're doing everything with a small hole, either in the groin, in other places, sometimes transapically, and rarely kind of transcarotid, and through a whole catheter system. And I think that's the wonderfulness in terms of, I think, cardiology. We've kind of made things easily accessible and not in terms of not going through the rigor of a full-blown surgery.
Yeah. And valvular replacements now are the percent of people getting TAVRs over surgery has been really skyrocketing over the last decade. Is that right?
Oh, absolutely. I mean, I think by the time, in the next decade, you're going to see a lot more individuals, having aortic stenosis and then being referred to for percutaneous or transcatheter approaches to this problem, which is severe aortic stenosis, where the doors of the valve, the last doors, the aortic valve, not opening well, usually resultant due to, basically, atherosclerosis, calcification. And you need to fix it because you need to fix it mechanically. And this mechanical fix is either surgery or now pretty much more transcatheter.
And who generally gets them? And I'm guessing that as the prevalence for aortic disease increases, severe valvular disease increases with age, because the largest proportion of people are older adults. That said, I also, my wife's, she was, I think, 98 years old when she got her own TAVR because she was symptomatic with heart failure and had valvular disease.
Your wife's
grandmother.
Got it.
Yeah.
Well, it's interesting. The way this procedure started about a decade ago, just over a decade ago, with the larger clinical trials, was that this procedure was done only on inoperable patients. And so there's really no medical treatment for this disease. The inoperable patients had an opportunity for treatment for the first time. And then the procedure was so widely successful that it was expanded to patients who were high risk. And then the procedure was so successful. So now this procedure is actually available to anyone with severe aortic stenosis who has 3 leaflets to their valve, not a bicuspid leaflet. There's a subset of people who are born with only 2 leaflets, and that's really the only group that we're not routinely offering TAVR.
And how bothersome is severe aortic stenosis? I mean, what are the major symptoms that people are living with severe aortic stenosis?
The original outcome metrics was just to help people live longer. So people could have a syncopal event and die following their arrhythmia with having had no prior symptoms. And so this is, Braunwald's classic triad of symptoms. So either an arrhythmia or heart failure or angina. And so the heart failure symptoms, the dyspnea and the angina are more often what can drive patients to seek treatment. And as this procedure has gotten a lot more popular, we're seeing, more requests for it.
And I think also syncope, I think also in that mix, it used to be, kind of running for the bus issue. Did you have a problem kind of running for a bus and you passed out? That used to be kind of the general, one of the big symptoms in terms of when you're asking for more, perfusion in the brain, you're not getting it allowed because the doors don't work, and then you're, made to do more. So, syncope is also something that's high on in terms of a symptom wise. High on the list.
And so we're talking about disease, aortic stenosis, that has a serious impact on quality of life for older adults. Is that a fair statement? We're talking about like chest pain, and we're talking about shortness of breath. We're talking about limited function and potentially even fainting.
Oh, absolutely. I mean, I think those classic symptoms are something that can basically end up really decreasing, quality of life. I had a patient many years ago who actually came to me saying that she was overweight and not doing much. I just feel like I'm not doing much. And I think some people in the spectrum also kind of adapt to their disease. So they know when they kind of get pushed to the roof, they're going to have some event, syncope or or heart failure or something. So they stay below the roof and don't ever do much. And then their overall physical activity kind of decreases.
That's a great way to put it. Ashok. Function is limited by the disease, and also symptoms, and sometimes those are commingled, and that we see people just doing less so that they don't have symptoms from the disease.
So I'm hearing TAVR can help both with symptoms, mortality, some big trials like the partner trial. And when we're thinking about the use of TAVR, because I'd like to get complications, I got one more questions before we do that. Is it just for symptomatic folks? What about like asymptomatic folks with severe AS?
Funny you mentioned that, Eric. My clinic is comprised primarily of older adults with either multiple chronic conditions or very advanced age. And I do have patients in clinic. There is now a more recent study that shows that very severe aortic stenosis, there is good evidence to suggest that we should do TAVRs for those patients, even in the absence of symptoms. Traditionally, in the past, we always waited for symptoms, but the interventionalists have gotten very good at this procedure, and it may be a little bit riskier to wait until someone is sicker than to proceed in the setting where patients have very severe stenosis.
Yeah, and I think specifically in older adults, this issue of symptoms sometimes is hard to kind of ascertain, because in the past, I remember when I joined 15, 20 years ago, we'd put some of these people on a treadmill to see how they do, what did their blood pressure do, even though that is a no-no in terms of the general audience of not putting anybody on a treadmill. In some people, we want to see their hemodynamic response. Now we've kind of evolved to try to get kind of corollary information. We often will look at kind of valve calcium. If the valve calcium score is high, it's kind of an indirect saying, well, even though this may not, he or she may not be symptomatic, the calcification of the valve, the look of the valve on echo, the calcification on CT are all reasons to say, let's do it a little earlier than later. And I think that's a general trend, because to take an 80-year-old or 85-year-old past hip surgery, all this significant gait issues, they're hard to kind of, get actually symptoms sometimes. So.
Yeah. So then the question becomes, what are the risks of doing this procedure? What are the complications?
So I can take it. I think, one of the big things of TAVR, and I've thought this a lot, it's really a remarkable procedure. I mean, I think although now we've kind of gone into the frame of, I would say like the Shania Twain reference of basically, it doesn't impress me much, okay, that we basically do this. But it's a remarkable kind of a procedure that's evolved from first man implants, what Gwen talked about in terms of the partner trials. And then now there's been a big issue of more TAVR valves on the market. There are more programs. We used to start, this with basically hybrid ORs. You'd have to do a TE, Foley, intubation, everything. Now it's basically, it's not an outpatient procedure yet, but it's really kind of shrunk. So I think the initial issues of mortality and all are still there, but now it's trying to kind of focus on reducing complications, reducing length of stay, and I think those are the big things that are really the focus, I think, in terms of the TAVR world.
When this procedure started, it was not uncommon for patients to leave with a pacemaker as well. But that's become much less frequent, although I wouldn't say infrequent at this point.
Yeah, and I think SAVR in terms of length of stay has always been kind of around 8 to 14 days, somewhere between 1 and 2 weeks. TAVR length of stay in the hospitalization was as much as 7 days, and is now starting to get into that 3 to 4 range or so, and occasionally less than 3 days. And but I think some of the complications is what you were alluding to, Eric. I mean, there are, you can kind of think about it as, when you do the procedure, you have to kind of find a place, femoral or carotid or apical. Yeah. And so vascular complications, and then pacemakers, what Gwen said, and some other things.
We used to worry a bit about dialysis in patients who have chronic kidney disease, but the occurrence of that is very exceedingly uncommon now.
No, I remember from the early partner studies, stroke was a complication with TAVRs. Mm-hmm. Is that still a common complication, or is that getting better as well?
Well, SAVRs basically are, again, basically between 0 and 5% for SAVR, meaning standard aortic valve replacements, are about 5%. In TAVRs, they can be as much as minimal to as much as 6%. We're not interventional cardiologists. There has been a progress even in that, in terms of reducing stroke rates by distal embolization protection and all those things, and depending on the site, and in terms of whether you do it femoral, apical, or carotid wise, which is really kind of a remarkable thing, doing the whole procedure from the carotid artery. So yes, they have, I think, reduced it quite significantly, but there's still work to be done.
I think that's a great question, because as this procedure has become more popular, we actually at the VA have done TAVR procedures in patients who are on dialysis. And so I would say that the risk of a stroke, we're doing procedures on patients that previously might not have been referred to us. And so I think that needs to be taken into account as well.
Yeah. And that kind of leads into this idea of what should we be doing, both not just after, but even before these TAVRs, and how should we be thinking about having these discussions? For a lot of older adults, survival is important, but it's not often the only thing that's important. Quality of life, feeling better. And if they do have a major complication, not something that they want, and thinking about what would they be willing to endure and go through. I want to jump into Gwen's paper in JAGS, because I think it touches some of these issues, and then maybe we can talk about afterwards, like what does or what should the periprocedural kind of care look like, and in particular thinking about collaborations too. Gwen, so you did a paper on the periprocedural code status in TAVR. What made you want to do this paper?
I have to laugh because Jim Kirkpatrick, who's the last author on this paper, approached me that there was interest by the college, our professional society in this question. What happens when patients come with severe aortic stenosis who have a do not resuscitate code status? And so the question was not mine, but I was very fortunate to work with a wonderful group of people, interventionalists, anesthesiologists, qualitative methods, researchers, methodologists, structural heart team, nurse practitioners, and just a very, very broad group of people to examine this question. So I'm not sure if that answers your question about how it came about. I think there was just a lot of enthusiasm and interest in this question.
What do you think brought on that enthusiasm? What was did you get a pulse of like what people were thinking?
I think at that point, we expected this to be fairly straightforward. And we thought that potentially we might be excluding a certain segment of the population or not. Yeah. And so that's when it got a little bit more interesting. We originally thought that this could be a survey where we could just reach out to programs and ask, hey, what are you doing? What are you doing for patients that come to your program like this? Turned out that wasn't the case. We really needed to have a talk about it.
Yeah. And you mentioned your clinic, right? I'm guessing a lot of frailty, older adults, people with varying preferences around life-sustaining treatments and code status. Is that right?
Absolutely. And potentially even somewhat more fluid than maybe we've traditionally considered them to be.
Yeah. Ashok, I got a question for you. Before reading Gwen's paper, if you were to think about the results of this paper, looking at policies and management around periprocedural DNRs, what would you think it would have shown?
Wow. So I actually felt that initially, before undertaking this project, that if you are a DNR, that you probably would not be offered TAVR. That was my general gist. I think this paper just kind of opened it up a little bit, showing that there's significant heterogeneity in this complex topic. I mean, I think that is that. I would not have expected.
I want to reiterate. Yeah, I want to remind audience. I'm referring to Gwen's paper, but this is Ashok's paper too, as you were an author too.
Absolutely,
so clarify. Okay, what did you do in this paper, Gwen?
So we first thought to contact TAVR coordinators in Washington and California states. So it was as simple as making a phone call and asking program coordinators what the informal practices and what the formal program policies and organizational policies were surrounding TAVR in patients who have DNR code status preference. So that was the first step. And would you like to know what we found?
I'd love to know.
I'll cut to the chase.
We're much more about results than methods on this podcast.
Okay. Well, it turns out only one program among 50-some programs we contacted excluded patients from consideration.
Excluded patients who were DNR from consideration.
Correct. Mm-hmm. Correct. So it was call back if you change your mind. And then we had approximately half a dozen programs that maintain DNR status, code status in the cath lab. There are patients who, if they arrest,
kept their DNR status the whole in the lab. So correct. If they arrested, they wouldn't do CPR on them.
That's correct. So it was not. Some of these programs were not speaking from the hypothetical perspective, but we're speaking from what their intended practice was, as well as their historical practice.
Wow. That's actually, that's the part that surprised me, that there are some places that actually don't revert to full code for these procedures, which is somewhat actually good to hear.
Right. And what was great about having a semi-structured interview was the opportunity to explore these topics some more. And so for some of these interviews, it was really an opportunity to be that Monday morning quarterback person and say, well, how has your practice changed as a result of maintaining code status in the cath lab? Has it changed? And so, obviously we had to be sensitive about patient-specific information, but the coordinators were able to talk globally about their experience over the years and how their programs have evolved and how they've gotten to the practices that they have over time.
Was there a general theme about how they evolved?
No.
A lot of heterogeneity.
There was a lot of variability. And I would say, talking with one program coordinator, there's that saying, if you've been to one academic medical center, you've been to one academic medical center. And I think that same dictum applies here. If you've talked to one TAVR coordinator about one program, you've talked to one TAVR coordinator about one program. There's a lot of
there's groups that just say they need to be full code for this procedure. One of the qualitative comments I loved was, we do not perform TAVRs on patients who are no code status. It's not a walk in the park. It's an expense. Why would you have a TAVR if you didn't want to survive? Was that?
I actually found that incredibly remarkable in terms of, I think I have to kind of back up here. I think the amount of work that Gwen actually did in terms of interviewing all of these programs and getting this in-depth understanding is really just, I think it's beyond, it's incredible. And so getting these kind of granular data was actually so remarkable. But you're right. The whole problem is when I talk to the interventionalists, they go, it's generally, they feel that. And how do you balance what they're feeling with kind of a little bit more global perspective?
And in some ways, it sounded like that was kind of the norm, is that for the procedure, there was a, temporary rescinding a DNR, 78%, there was that belief. Not necessarily policy, right?
Right. Practice, informal practice. So the vast majority of programs did not provide policies, and those programs that did provide organization level policies, their practices more often did not match with those policies.
And it also sounded like, so you had the vast majority, nearly 80%, you had to temporarily rescind if you're going to get the TAVR. And the question then is, how long, what is temporary rescinding? And it sounded like the time frames, about 40% was like less than 48 hours post TAVR, about 44%, 48 to discharge. And then about 20% was greater than 30 days post discharge. How do people come up with these numbers?
Well, that's a great question. And I didn't ask specifically, how did you get to where you are, unless that flowed organically in these semi-structured interviews. It wasn't one of set interview questions. And we actually had 3 cardiologists code the interviews and what the practices were. We excluded a select number of programs. I think we had 4 programs where we really could not determine a consistent code status practice, having reviewed the interview transcripts. And so I think for as much as there was variability in practice, I suspect that there was variability as to how programs came toward having that particular practice.
But there's also something potentially special about 30 days.
Right. And that was very explicit on the part of program coordinators.
What's special about 30 days?
And that was unexpected. So this actually blends nicely into the second part of the study. So 30 days was mentioned because all TAVR programs are required to report their outcomes to a national TAVR registry. And programs are evaluated, their performance, and the interventionalists who perform these procedures, there are metrics, mortality and outcomes. And so those programs that mentioned that they maintain code status for 30 days, some of them were very explicit, their reasoning, which was that their metrics, their outcomes could potentially be affected if patients reverted their code status prior to that 30-day mark.
Did that surprise you, Ashok?
Well, even though I'm not an interventionalist, I think I've been attuned to a lot of the proceduralists, and I think that is a big issue in terms of policy. How do you judge a proceduralist, and they want to kind of help in terms of people who have got, significant morbidity, significant, other things. But when their hands are tied in terms of, I think it becomes, especially in the day of public reporting, New York and California, I think those are things that I have learned from my interventional colleagues are important for them. But I think papers like this are kind of the first step to really kind of address, are those policies really helping people? And how do they help? Mm-hmm. I'm blanking on the hospital readmission program had a lot of issues in terms of CMS, in terms of, not actually delivering on what it was actually meant to do. So I think public policy is something that can handcuff interventionalists when they're really trying to do the best that they can.
And I think that speaks a bit to organizational incentives. And so, like you're saying, Ashok, that, when we incentivize practices like get with the guidelines and that type of thing, it's really with good intentions. And so I think there's always consequences when we incentivize certain behaviors. It was very helpful, I think, on the part of the coordinators to be so forthcoming about what the limitations are of some of the current practices that we have, and that there may be some disincentives that we're not recognizing.
Seems like there's a great opportunity here for a follow-up study where you interview older adults who are candidates for TAVR, who are DNR at the time that they're candidates, and see what is it like to be told by those programs that don't take patients who are DNR, to be told you can't have this? What is it like when they tell you that you have to be full code for a period of time? And what did you think when they told you it was, 30 days or some longer time period? And sort of get the understanding of what does it mean to be full code versus DNR in an intervention room where it's, they have an incredible amount of control over what happens to you. So the likelihood that you will actually get to the point where you are, you have complete cardiopulmonary arrest, and a code needs to be called is very slim, I would think.
So that's a great question. And I think before we get to what would patients and family members say, which I think is critically important, we actually looked at what happens to these patients. So we had the opportunity to look to the registry and see how these patients do. Like what happens? Like you made the comment that these interventionalists have so much control over what happens to these patients in the lab because of their code status, right? That if they code, they're going to live or die on the basis of their code status. Well, in the end, we stratified by code status practice. So the second part of the study, just very briefly, we examined patient characteristics, risk status, and outcomes. And we stratified those by code status practice. And it was not clear what clinical differences between programs contribute to the observed variability in practice. It's a long way of saying that there was really only a handful of patients in each category that underwent cardiac arrest or who had a hospice discharge or had an unexpected outcome like that.
Very few, and there was no linkage to the policies of the program.
Well, we stratified by practice, by the informal practice. And when we looked at the outcomes, and these were admittedly aggregate patient data, unadjusted, these were very rare events. So I think this notion of getting back to your question, what would patients say about this?
Yeah.
And I don't know. In our discussion section, we went back to the surgical literature because this has come up, for patients who've had operations. And there's this notion of surgical buy-in. And some patients, there's been some work that has shown that some patients actually expect to have a discussion about code status, and they expect their code status to be reversed. And so I don't know if that's the case for this particular population with all of the comorbid conditions they have, frailty, and what their outlook is on life. But I think that's a great, great, great question and consideration. So Ashok, what do you have?
No. I think this study is really just the first step in terms of getting to a lot of more unanswered questions. So I think that's how I look at it. It's at least opened the door for more work in this area.
Yeah. I also, looking at the data, it looks like in-hospital arrests are rare, but still you're looking at like 1 in 50 to 1 in like 80 patients who get a TAVR have an in-hospital arrest looking at this data. So it was like 1 to 2%, about 1.5 to 2%. Is that right?
And that's just it. This is a high risk population, even among the lower risk patients, right? Yeah. These patients who have aortic stenosis and coronary artery disease are most frequently coexisting conditions.
Yeah.
So prior literature has shown that patients who designate themselves as DNR do have higher mortality. So we thought we might see some sort of signal, and that we might need to do a more extensive study with a lot of adjustment, statistical adjustment.
Well, it's interesting because there's a lot of confounding going on in that statement, which is somewhat like resolved if you don't look at the patients, you look at the program policies, and you're not seeing that. And you wonder how much of that is just people who are DNR are just significantly sicker than people who are full code.
Right. And I think that's in part why the practices may be different than the policies, because the patients are different. One program, is located across from an assisted living facility, right? Yeah. So that population is probably very different than the one that's located in an, urban environment.
Well, I guess then the question is, should there be more standardization? Should there be like specific guidance on how should we handle advanced care planning, serious illness communication, code status in the periprocedural place? Because I also think like a code in the lab is different than a code 3 days later in the ICU when things are crumping, and the outcomes are different. What are your thoughts on, more guidance and guidelines around this?
If I may jump in here, I think part of the issue is just having a seat at the table, making sure that geriatricians and palliative care physicians are actually at the table, because questions like these, I think, inherently will come about only by those who are experienced in doing this. So that's one. Two, I think, is generally kind of making sure that standardization is first getting some standardization of what baseline characteristics are there. The comprehensive geriatric exam, I think there are a lot of programs that do portions of it, understanding, what all it is, standardizing it, and then also, and then using it for two things. One is to say, is this person actually fit enough for the procedure? Meaning, is there a matching? And then the question is, of course, outcomes. This is the big thing. And I think this is where the geriatrics and the palliative care perspective really needs to be brought out. The geriatricization and the palliation of cardiologists. What outcome? We're fixated on basically MACE outcomes in terms of reduction of any major adverse cardiovascular event. we should also be fixated on reducing SAEs in terms of serious adverse events. And then, of course, the biggest challenge is trying to get an understanding of patient-centered outcomes. Meaning, I just want to be able to walk with my wife 3 days a week, holding her hand. That's an outcome that I want. I mean, right now, I can do 2 days, okay? So this is the kind of, I think, at least the pie in the sky dream that I think we can try to quantify it a little better and then over the next decade. And I think using statistics, all those kind of stuff, different statistics can actually help to make these processes easier.
That's why coming on this podcast was such a privilege for both of us. We were absolutely delighted to have the opportunity to speak with geriatricians and palliative care clinicians, because this is where the weeds is really where it's at. We need to know what outcome are we striving for, and when is enough, and when have we achieved what we set out to do? And those are all very difficult questions that existed long before this study and will exist long after this study. And to the extent that we can work with our colleagues who are much more expert in communication, I think we're going to get closer to achieving the right outcome for the right patient at the right time.
Yep. My last question for both of you is that I'm going to drill it down to, I'm seeing a patient in my clinic, and they're going to get assessed for a TAVR. It's looking like they're going to get it. Should I talk about code status at all with them? How should I handle that issue with my patient that's in front of me as a non-interventional cardiologist? I'm not going to be involved at all. I know a little bit maybe about their program, but not a lot.
I love that question.
Go ahead.
Ashok, do you? Okay. So I know there's been a lot in the literature about advanced care planning, and it's become somewhat controversial. And I think that controversy is potentially going to be very fruitful in helping us make in-the-moment decisions. And so I think, for me at least, when I see patients in clinic, I try to get a sense of under what circumstances would this person presumably like to be a full code, recognizing that this person has probably never been in the room or participated in a code. And so that's where dialing back and saying, ultimately, what matters most to you, and how does that translate into clinical practice? And translating into clinical practice isn't just a matter of going to the lab. So, for example, in these interviews, some programs actually would do partial codes, and they would talk to patients about that. Should we give you a shock, or should we do medications? And that's a very, very challenging discussion. And I think we need a lot more research as to how best to approach that. But in short, I think in talking with your patients, I think for me, at least, when I work with geriatricians, which is fairly often now, and I reach out to them a fair amount, is really trying to get a sense of what matters most to patients and what a good day looks like and what your goals are. And it shouldn't just be, I want to breathe better if I have this TAVR, but what can I do because I breathe better?
Mm-hmm.
I mean, it can't just be, well, I want to breathe better and be out of distress, which I think is an outcome in of itself. And that may be the outcome. But if there's more, if it's not that I'm just going to be breathe better, but I have to breathe better so that I can go do this, we want to know that there's also that go do this. Because if we can't get that person to ever leave the hospital and go do that, then it would be good to know that up front.
Yeah, and I think I'll make it 2 seconds. I think part of this is really just saying, yes, I do discuss, in terms of code status. I also try to say, and I think expanding on what Gwen was saying in terms of what matters most, trying to make it smart. Is it specific, measurable, achievable, relevant, and time limited? To kind of say for physical functioning, cognitive functioning, and then you start building the code status discussion on what you want. That's how I've done it.
And I love the idea of like really thinking about like, what does home look like for this person? How are they functioning? How long has this been going on for? Because like, even will the TAVR even fix the problem as far as function if there's something else that is causing it? And for a lot of our older adults, there is. Like, they don't know that I'm not the man they think I am at home. Alex, how was your intro to the song?
That's my cue. It's a human sign when things go wrong and the scent of it lingers and temptation is strong. A cold, cold heart, hard done by you. Something's looking better, baby, just passing through. And I think it's gonna be a long, long time till touchdown brings me round again to find I'm not the man I think I am at home. Oh, no, no, no. And this is what I should have said. I thought it, but I kept it. Cold, cold heart, hard done by you. Something's looking better, baby, just passing through.
You found your rhythm on that one, Alex.
You said that high part was really high.
I love that you reached for it.
Gwen, Ashok, thank you for joining us on this podcast. It was fabulous.
Thank you very much for having us.
It was a pleasure.
And as always, thank you, Archstone Foundation, for continuing to support, and to all of our listeners. We'd also like to thank the generous support from our listeners who've donated $250 or more to the Jerry Pal podcast, including
Meg Walhagen, Thomas Quinn, Rochelle Bernacki, Louise Aronson, James Tulsky, Arden O'Donnell, Mike Steinman, Marianne Forcia, Ashok Krishnaswami, Nancy Lundeberg, Gail Cooney, David Schiffling, Cheryl Phillips, Jessica Ng, Harry Hahn, Elizabeth Chung, Kathy Foley, Rochelle Bernacki, Christine Ritchie, and Lloyd Woolstadt. Thank you very much.